our webinar on the BioS project, and welcome to Murnau. Murnau is located in the south of Germany, and we are located here in this hospital right in front of the Alps. So you know now to whom you are connected. My name is Peter Augard. I am the director of the Institute for Biomechanics, which is located here in Murnau. And I'm also a professor for biomechanics at the Paracelsus Medical University in Salzburg. And I'm working on clinical studies, developing and conducting them since the last 15 years. And I'm leading you through this online webinar course today. So what will be the content of this course today? If you have participated on the seminar yesterday, you have seen that BIOS analysis can deal with variables that have multiple outcomes, and also that have a continuous spectrum of answers. So you can use this art of information to do the analysis you have seen yesterday. Today, we are completely at the other end of the spectrum of data. We have a single outcome variable that has only one answer, yes or no. So it has a dichotomous outcome. So it's very easy data to deal with. However, you have still the possibility to have a lot of interpretation on these data. And today you will learn how to interpret this data, how to use 2x2 or contingency tables to evaluate and interpret the data. And then if you have the data put into the table, what parameters you can obtain and what information can be derived. Just information, we have several examples that we conduct during our webinar today, and we did a rough estimate of these variables that we use in these examples from the current literature, but they should not be used for any diagnostic purposes on your side. They are not fake, they are real, but they may not represent the actual numbers for your population or for your individual patient. So the learning objectives, they are about the different studies we deal with. So you can interpret cohort studies, you can interpret case control studies, and you can interpret diagnostic studies. So what you learn today will be useful for you if you plan to do or analyze studies that have a cohort, a case control, or diagnostic background. But you are also will be able to interpret those studies if you read them in the literature. And if this cohort or case control or diagnostic study, there's a lot of information in there that is sometimes not clearly represented and sometimes been hidden between the numbers. And what you learn today will be how to calculate the numbers and know more about the numbers that are hidden in those studies. For example, risks and odds, prevalence, specificity, sensitivity, etc., etc. So a lot of information, if you look into these case control or cohort studies, is associated with risk. And the word risk is sometimes difficult or not clearly described. So risk can be interpreted and communicated in a different way. And I'll give you just a few examples about the fact of breast cancer. So you can say 1 in 8 women will develop breast cancer during their lifetime. So this will be the lifetime incidence of this type of cancer. Then you can say the probability that a woman at age 55 has breast cancer is 0.6%. This would be a point prevalence. You can also say that 260 in 100,000 women aged 55 develop breast cancer each year. So this would be a yearly incidence. And there are several other examples that are out there. And if you look into databases, you can find these examples, and you will learn today how to interpret these informations. So in order to give you the opportunity to work with us and contribute to this live webinar, I will ask you the following question. What is the probability that a patient with a positive test after a test that has been performed on that woman actually has breast cancer? What is the probability that after a positive test you actually have breast cancer? Please use the Mentimeter with the code above to give your answer. It seems that you are not very active. We have 30. Yeah, this looks good. Now much better. So you go to the doctor, you're concerned about having breast cancer. You decide that you go to a screening test and you obtain the result that you have a positive indicator for breast cancer. What is the probability that you actually have breast cancer? Okay. I need to do. Okay, so the answers, they range between 27, so they are very common. So most of you think that there is a fair probability that an individual has breast cancer. Actually, the correct answer is 7.5%. So it's actually not that high. So how can we obtain this number, and why do you think this number is correct? And we will learn that now in the next 15 minutes. So in order to obtain this information, we use a 2-by-2 table. And I briefly introduce you into this 2-by-2 table concept. A 2-by-2 table has a row and a column, and typically in the column it is depicted whether an individual has a disease or does not have the disease. And then depending on whether it's a diagnostic study or a cohort study or a case control study, you do have either the test or you do have the exposition on the row side. So the test, for example, is positive or the test is negative. And so there can be overall 4 different combinations that can be true for such evaluation. So often it comes in very handy if you use or make this table 2-by-2 a bit larger and add up the numbers of the rows and add up the number of the columns. So this would give you the total number of people you analyzed, A plus B plus C plus D. This would give you the total number of people that have been tested positive. Those are the number of people that have been tested negative. Those are the number of people that have the disease. And those are the numbers that don't have the disease. And so from this, these ABs can calculate all these different parameters. I want to just know if you bring in some information or some knowledge about what are the features of such a table and which statistical parameters we can now derive from this table. And so if you know something about those parameters that can be derived, please tip them into the Mentimeter. Okay, so seems that we do have a lot of experts attending this course. They already know a lot of the information that can be obtained from those tables. And if you look at those answers, you can see that there are more parameters that you can derive than are actually numbers in the table, which is quite interesting. So you have 4 numbers and can obtain at least, I mean, all these answers are correct. And so you can obtain at least 10 different parameters from a table with only 4 numbers in it. So I will go through those parameters that are probably most interesting and those parameters that we need in the time course of this webinar. So firstly, we have the prevalence. The prevalence is the proportion of the people with a disease at a given time. So these are those people who have the disease at a given time. So that are positive in this column here. So it's A plus C. So these are all the people that have the disease, and the prevalence rate, so the proportion of people, is then A plus C divided by the total number. This is the percentage of people that have the disease. That's the prevalence. This is actually the same as the incidence. The incidence is the proportion of people which develop a disease. So the prevalence is given, for example, in a case cohort study or in a diagnostic study, while the incidence can be obtained in a prognostic study or in a controlled observational study, because here you additionally have the time during which the people develop the disease. Now, in the first part, we deal with diagnostic studies. So we talk about diagnostic studies and their results. A diagnostic study typically starts with a test result. We will later on have the example of COVID-19 test, and the result of the test is either positive or negative. It's a dichotomous outcome in which either you have a positive or negative test result. And with this test result, interestingly, you don't have an answer, but you predict probabilities. So you predict a probability of a patient having the disease or testing positive for the disease. And a diagnostic study is always a cross-sectional study. It's not prospective in time. It's cross-sectional at one point in time. So if you do a diagnostic study in one individual, you have a diagnostic test on an individual. If you do it on multiple individuals, it's a cross-sectional overview of that population you look at. And if you look at this in a term of a study, you can find then, for example, correlations between risk parameters and the result of the diagnostic test. For a diagnostic test to be interpreted, it's important to know its sensitivity and its specificity. First, the sensitivity. The sensitivity is the rate of those people who have a condition or a disease and test positive with the test. So this number will tell you how sensitive the test is. So it tells you the ratio of those being tested positive, A, divided by those that are actually having the disease. So the ratio is A divided by A plus C. And it gives you the probability of test being positive if disease is present. It's the probability of positive if the disease is present. In contrast, you have the specificity, and the specificity gives you the true negative rate. So the specificity is actually those that don't have the disease and are being tested negatively, being tested correctly, divided by all people who have the disease. So it gives you the probability that the test is negative in the absence of the disease. So specificity is always related to the people who are healthy. Sensitivity is always related to people who are sick or ill or have a disease. But this is not typically the number or the information you are interested in, because you don't know if you have the disease and you go to a doctor and make your test. And so what you would like to know is what is the probability of the disease after the test is positive. So you go to the doctor, you have the test done, and you get the result. This might be positive or negative. And then what you want to know is how probable it is that I am, after having that test being performed, I'm sick or I'm not sick. And this is the positive predictive value. It gives you the ratio of those that are being tested positive if they have the disease among those that have the disease. So that is the ratio A divided by A plus B. Very similarly, the negative predictive value gives you the probability that you don't have the disease if the test is negative. So you want to know, can I be sure that I don't have the disease if the test says I don't have it? And this is the ratio of those being tested negative, not having the disease, divided by the number of people who don't have the disease. So this is the negative predictive value. I'd like to inform you about the chat function. You know about the chat function in our webinar, so please use the chat function if you have any questions. I should actually use the chat function as well to see if there are questions. Okay, so there are no questions so far. We can move on. So now, as an introduction, we had the example of the breast cancer diagnosis using mammography. And we want to go through this example to calculate the actually positive and negative predictive values for these tests. And as we have seen in the overview, many of you thought that the positive predictive value, so the probability of having the disease after the test is positive, is much higher than it in reality is. So what is the first thing we need to know? This is the prevalence of the disease. So if we look for the number of people that are women and that are aged around 55, we want to know how many of them have actually breast cancer. And this gives you the prevalence. And so if you look up the literature, you find that the prevalence at the age of 55 for women is around 0.6%. This comes from large cross-sectional studies that use this diagnostic test to detect breast cancer with mammography. So if one of these women has breast cancer, then the probability that she has a positive mammography result is 94%. What does this inform us about? What does this mean? So this is about women who have the disease and the probability that she has a positive test when she has the disease. So this means this number is the sensitivity of the test. So the test mammography has a sensitivity of 94%. So there's one more number that we need, and this is the specificity. And the specificity is also a number that is associated with the mammography test. And this here is specificity, which means if one of these women does not have breast cancer, the probability that she will still have a positive mammography is 7%. This is 1 minus specificity. So the specificity is 93%. So we have a test that has a sensitivity and a specificity that is provided for this test. Now the individual comes to the doctor and gets a test, and we want to know what is the probability that the patient that has a positive test actually has breast cancer. Now we use our 2x2 table and we go through this quite quickly. So this is the information we have. This is the prevalence of the disease, the sensitivity, and the specificity of the test. There's an error here. The specificity must be 93%, not 7%. So we fill in this table. We start with a just thought of number of people in the population, which would in this case be 20,000 people who are being tested, and the prevalence of the disease, so the number of people who has the disease, is 0.6%. So if we have 20,000 people, then the number of people who actually have the disease is 120. So out of those 20,000, 120 actually have breast cancer. This means that 19,880 don't have breast cancer. And this gives us already a hint that many people who are being tested actually don't have the disease. Now we have a sensitivity. Again, sensitivity is for the people who have the disease, which is 94%. So 94% of those people that have the disease are being correctly tested, which would be 113 people. This means that 7 people are having a negative test result despite the fact that they have the disease, which is not the real problem. The real problem comes on this side, on the people who don't have the disease and being tested. And this again, you have the specificity. This contains the people who don't have the disease. So 1 minus specificity, 7%. So 7% of those people who don't have the disease are being tested positive. So they are wrongly tested positive, and this number is 1,392 people. Correctly tested are those 93%, 18,000 people. So now we have filled in this 2 by 2 table, given a prevalence, a sensitivity, and a specificity of the test. Now we can use this table to calculate the positive and negative predictive values. So the positive, or let's start with a positive predictive value. Those are those that are being tested positive of all those that are having the disease and being tested positive among all that have been tested positive. So 113 have been tested positive and have the disease. However, 1,392 have been tested positive but don't have the disease. And the total number of women being tested is 1,500. So the positive predictive value is actually 7.5%. This is the probability of having the disease if being tested positive. Similarly, the negative predictive value is the ratio or the probability of being negative if the test result is negative. And this is quite high, which is this 18,400, which are those that are testing negative and actually are negative, divided by the total number of those being negative. So this is 99.9%. Now, how do we evaluate this diagnostic information? We have a prevalence in the population of women aged 55 of breast cancer. We do have the sensitivity and the specificity of the test. And this is the information we can obtain from the test. So I need to have this marker here. 7.5%. So the positive predictive value is 7.5%. So if you are women being 55 years old and you go to a mammography, to a breast cancer screening with mammography, the chances of having the disease after being tested positive is 7.5%, while it was 0.6% before the test. For those individuals, for those women who have a negative test result, they can now be pretty sure, 100% sure, that they don't have breast cancer. So the screening test is good to exclude the disease, but it's not pretty good in predicting that you have actually the disease. Okay. And we continue on. Are there any questions from the audience? Yeah, we have a question from in here.
What would be the false positive rate in this case?
Okay, so there, if you didn't hear that, there was a question from the local audience here that was about the false positive rate, the rate of false positives. Let me go back here to this information. So the rate of false positives would be the number of false positives, those that are being tested positive but not having the disease, divided by those that are actually negative in the disease. So this would be the rate of 1,300 divided by those 20,000. So this would be approximately 7%. So the false positive rate would be 7% in this case. So quite similar as the positive predictive value. But this is not, there's another measure which would be the false discovery rate. So the false discovery rate is the ratio of those that are being tested positive, but they don't have actually the disease. So this would be the 1,392. All of those that are being tested positive, this would be 1,500. And this would be actually around, I don't know, 90%. And what does this false discovery rate mean? This means that you have a 90% chance of being tested into the wrong group. So the 90% of the people are tested wrongly. We will see that later on that this has a big relevance for the current COVID-19 PCR testing. So false positive rate and false discovery rate are also numbers that can be calculated from this 2x2 table. So this was information about diagnostic tests or diagnostic studies. But the 2x2 table can also be quite handy when you analyze case control studies or cohort studies. And case control studies are actually the probably most wrongly cited studies among all studies, because a case control study doesn't mean you compare cases with the controls. You compare cases with controls, but there's a very, very important condition for a case control studies for being a case control study, and that is that a case control studies starts with the condition. So it is a retrospective study. A case control study identifies individuals that have a condition, and then they look, for example, for an exposition. So in this case here, in this example, the condition would be a heart attack. So you start with people that have the condition of having had a heart attack, and you search for something that could have caused this heart attack. And then you look backwards in time and you ask those individuals if they were, for example, exposed to cigarette smoking. So you start identifying the group of cases and look for their exposure. And then you look for a control study, for control group. You identify individuals that don't have the condition, they are not having a heart attack, and you look also for the exposition. But you always start with the cases, and you go backwards in time, and you look whether there is a condition that might be responsible for the development of the disease. So again, case control studies backward in time. You have one group of individuals here that have had a heart attack and a group of individuals not had one group that not had a heart attack. And then you look and you ask them, have you smoked in the past 10 years, for example, and you identify individuals in the control group that have smoked, and you identify individuals that have smoked in the cases group. Now the question is, can you now, from counting the individual numbers, calculate incidence, prevalence, and risk? Can you calculate the risk of being smoked and developing a heart attack? Can you calculate the incidence of a smoker developing a heart attack, or the prevalence of smokers for having a heart attack? And the answer is no, you can't, because it's a study that was conducted backward in time. You can't calculate risks, you can't calculate incidences, and you can't calculate prevalences, because it's just not a causative relationship you are looking at. You're just looking at factors that may have some association with the outcome, having a heart attack. So then case control studies are worthless, or is there information in conducting a case control study? And now, one possibility to look at a potential outcome of case control studies is again the 2-by-2 table. So you have people who had a heart attack and those that don't have a heart attack. By study design, the total number of those that had a heart attack is 100, and those that didn't have a heart attack is also 100, because that's your case control study design. You identify people with the heart attack, and you have a control group that doesn't have the heart attack. Now you count among those that had the heart attack, so the group of cases, how many had provided the information that they smoked in the past. And you can obtain this number just by sending out a questionnaire to those individuals, which is a quite easy study conduct. So in the group with the heart attack, of the 100 people you identify for your case group, 40 had smoked and 60 had not smoked. And you do the exactly same thing in your control group, and you identify 20 people who have smoked and 80 people who had not smoked. And this is the information that is being provided in this 2-by-2 table. Now, can you obtain any worthwhile information from this table? And we have seen before that in a diagnostic study, we can calculate the positive and negative predictive values, while in a case control study, we need to calculate something different. And what we can calculate in a case control study is the odds. The odds is the ratio of a condition or a exposure and the exposure or the condition in the other group. To make that clear, we have the example. You can calculate the odds of having smoked in the group of those that had the heart attack. So in this group of 100 individuals that had the heart attack, the odds of having smoked is the number of those that had smoked to the number of those that had not smoked. So it's 2-by-3. So if you had a heart attack, the odds of having smoked are 2 divided by 3, 0.66, 60.6%. In comparison, the odds of having smoked if you have not had a heart attack, if you are in the control group, is 20 divided by 80, is 1 divided by 4. So the odds of having smoked, if you have not had a heart attack, is smaller than the odds of having smoked if you had a heart attack. Information, a little bit. What you can do is you can calculate the ratio of the odds. And the ratio of the odds, this is a bit more informative. So if you calculate the ratio of the odds, which was 2/3 for the people with heart attack and 1/4 for the people with no heart attack, you calculate that the odds ratio is 2.7. So what does this ratio of 2.7 now tell you? It tells you that it's 2.7 times more likely of having smoked if you had a heart attack as compared to having not had a heart attack. Is this really good information? It would have been better if you would be able to predict, if you had smoked, whether you will develop a heart attack. That is something you would be interested in. And this ratio here is just the opposite. It gives you the odds of the exposure, not the odds of the disease. However, although this information is not directly available from the study design, there is a mathematical trick. And for those of you who are interested in mathematics, you can listen the next 2 minutes. For those of you who are not interested in the mathematics, you just play around with your chat function and ask questions. So if from the case control study, we can obtain the information that if you had a heart attack, it is 2.6 times more likely you smoked. This is the odds ratio of the exposure. So the odds ratio of the exposure is the probability of having smoked in the condition of a heart attack divided by the probability of having not smoked under the condition of a heart attack. This is A divided by C divided by B divided by D. And now if you do the mathematical rearrangement of these this formula, you can use the mathematical rules to develop this formulation here. And this actually is the probability of having the heart attack in the condition you have smoked divided by the probability of having a heart attack having not smoked. So this now is the odds ratio of the outcome. So after this short mathematical excursion, we now obtain the information that actually the odds ratio of 2.6 for the exposure is the same as the odds ratio of the outcome. And this means that if you smoked, it is 2.6 times more likely you had a heart attack. So, yeah, sure, that's a question. Statistical test to do. Yeah, let me briefly try to finish this this slide, and then I'll answer your question on the next slide. So there was the question: is there a statistical test for this odds ratio? Which is a good question, and I come to that soon. I just would like to finish with this mathematical trick here. While this mathematical trick is true, it does not really mean that you can conclude this, because the study design still is a case control study. And the identification of patients and controls might have been caused by very, very different backgrounds. So there might be a lot of bias in finding people with a heart attack, depending on where you are, which population you are looking at. So the bias is quite big, so that the conclusion that smoking increases the likelihood of getting a heart attack cannot be really drawn from this case control study, although the odds ratios would be the same if it would be true. So while this is still true, this might be affected by your study design. If you have a lot of arguments that your study design in your case control study is free of bias, then it's very likely that the factor, the odds ratio of the outcome is 2.6 or close to 2.6, and then smoking might have caused the heart attack. But it's because of the study design, it's not a causative study design, and you cannot be 100% sure that this is true. Now let me come back to this question about statistics. So we have seen the odds ratio can be calculated with this factor, and you can calculate p-values and confidence interval for this odds rate. Now please lean back and think about what is more informative, the p-value that is obtained for this odds ratio or the confidence interval that can be obtained for this odds ratio. So while the p-value tells you the probability of this value being found again in another study, which is very, very high, it's 90.99%. The confidence interval tells you a little bit more. It tells you what would be the range of odds ratios that you can obtain in conducting these studies. So the real odds ratio that you obtained in this study, which was 2.6, could be anywhere between 1.4 and 5. So if you conduct the study again, it could easily be 4.5 or it could be 1.5. So it could be anywhere in between here. So this information gives you the security about how confident you can be that the odds ratio is in that area. And there are formulas to calculate this confidence interval, which you can look up anywhere at the internet. And there is also a test to calculate this p-value. And this was this question we had from the local audience. What is the test to be conducted to obtain this p-value? And this would be a chi-square test. So if you anywhere would like to calculate that p-value for an odds ratio, then you would use a chi-square test. So this was the information that you can obtain from case control studies. And now the last study design we want to touch upon is the cohort study. Cohort studies, in contrast to the case control studies, they are prospective in time. So they go forward the timeline. They always start with a patient population. So you identify a patient population and you divide the population between exposition or treatment and control. So we have two different groups and you observe those two different cohorts over the course of the time. And at some point during the study, or at several points during the study, you measure an outcome. And in this case, the exposition would be a drug treatment. So you have a group of people that is being treated with a drug and a group of people that does not obtain the drug. And the outcome that you measure is whether or not these individuals develop heart attack. And you control both groups. So you look for the outcome in both groups. So again, this is the example. You have the whole number of individuals you have identified as your population or your patients or whatever, and you divide this population into one group that obtains the drug or has an exposition, and one group that does not obtain drug. If you have a very good study design and you can randomize whether an individual obtains a drug treatment or not, then you have a randomized controlled trial in this case. But it could be the case that you don't be able to randomize your individuals, then you have a prospective cohort study. In both cases, these are experimental studies. In both groups, there are individuals who will develop a heart attack and those who will not develop a heart attack. And again, you can use the 2x2 table to analyze the results of this study. Now I will be a little faster because you're already familiar with this concept of 2x2 tables. And now you see that the numbers are different as compared to the case cohort studies. In the case cohort studies, we had an equal contribution between people with heart attack and people not having a heart attack. And now we have an equal contribution of people who obtained the pill and people who did not obtain the pill. So we have 100 people who obtained the pill and 100 people who did not obtain the pill. From those who obtained the pill, 2 developed a heart attack, and 100 people who did not obtain the pill, 4 developed a heart attack. So out of our 200 people, 6 developed actually a heart attack. Now, is this pill good or bad? Does this prevent heart attack or not? How can you measure the effect of the pill on the outcome of a heart attack? How do you assess this? Now, firstly, you can calculate the incidence. You can calculate the incidence because this is a prospective study. And it's pretty easy to see the incidence in the case of taking the pill is 2%, and the incidence of taking not the pill is 4%. So the incidence is higher in the case you are not taking the pill as compared to having taken the pill. So this gives you already a hint that the pill has some effect. Now, again, you can calculate the odds ratio, which in this case, you can do it, but it doesn't make that much sense because much more information is obtained in the risk ratio. So the risk ratio is the risk of developing a heart disease for those who are taking the pill, 2 divided by 100, divided by the risk of those who are taking not the pill, 4 divided by 100. And you see the risk ratio is around 0.5. It's quite similar as the odds ratio because it's a rare decision. So it's a rare disease. It's a rare condition. It's only 2%. If the condition is less than 5%, then the odds ratio and the risk ratio is quite similar because the numbers here, the dividers are large and they are comparable to the dividers here and the risk ratio. So it's for rare diseases, odds ratios and risk ratios are actually quite similar. What does it mean, a risk ratio of 0.5? If the risk ratio would be 1, that would mean that there would be no difference in the ratios in one group as compared to the ratio in the other group. So the risk ratio of 1 would mean there's no difference in taking the pill or not taking the pill. If the risk ratio is actually small, this would reduce the risk in those who would take the pill, in this case, by around 50%. So this gives you a risk ratio of 50%. A risk ratio means that the risk is reduced by 50%. You can also calculate the absolute risk reduction. This is a different number. This is the difference between the risk of developing a heart attack in those not taking the pill minus the risk of developing a heart attack for those who are taking the pill. So the difference is 2%. So the risk ratio reduction is 50%. The absolute risk reduction is 2%. How do we now interpret this? Is this large or is this small for being a good effect? So the risk is reduced by 50%, but the risk to begin with was actually pretty small. It was only 4%. And you reduce it absolutely by 2%. So you can consider this as a large reduction or a small reduction, depending on whether you develop a heart attack or not. For those 2 individuals who develop the heart attack, it would be effective. But there's one information that you can add, and this is the so-called numbers needed to treat, the NNT. The NNT is 1 divided by risk reduction, and the number of needed to treat means that you need 50 people to treat to avoid 1 heart attack. On the other hand, 49 people are being treated with a pill, and in those a heart attack would never have been developed. So in order to reduce or to prevent 1 heart attack in this population here, you need to treat 50 individuals. So this is not very effective because you need to treat many people. And this is mainly related to the low incidence to start with. So you treat people who have a low incidence of developing the disease. If you would treat people who had a higher incidence of developing the disease, then it would be much more effective. Okay, are there questions so far for the diagnostic studies, the case control studies, or the cohort studies? So we already used the first hour of our time of the webinar in order for all of us to fresh up and take a bio break. We will pause the webinar for 5 minutes, and we will be back in 5 minutes for the second part, in which you will have the opportunity to use this information that you have learned now to calculate the PPVs and NPVs for the current pandemic situation of COVID-19. Okay, so let's be back in 5 minutes. So, after some coffee and some refreshments, we are back again, motivated to go into the last part of this BioS webinar. We will now tackle the question, what does the result of a SARS-CoV PCR test actually tell us? So this is a very up-to-date question in which most people have difficulties actually interpreting the findings from all these data that are available on the internet and even on journal websites that try to present the test results of PCR tests. And it's also sometimes confusing for medical doctors or individuals being tested. What do they do with their test result? And what information can actually be obtained from having a PCR test result? And what we now want to do in the next 30 minutes is to analyze the information that is being obtained by such a test. And we want to use all what we have learned during the analysis of diagnostic tests during this webinar. We will start with just an example from our hospital, but it can be any other condition. It doesn't need to be a fracture. It doesn't need to be any trauma or disease at all. For an individual that obtains a PCR test, it's just an example for the doctors that work at our hospital here in Monau that have the duty to deal with these type of trauma, with this type of fractures. And so this individual, Frau Meyer, has an ankle fracture, and she suffered that fracture while she was working as a waitress in one of the hotel in the Alps. And she was brought to a small hospital there and was stabilized with such a fixator frame and brought from that smaller hospital into our trauma center, where she now should be treated for her fracture. She has no fever, she doesn't cough, she claims that she had no contact with any persons that were tested positive for the coronavirus, and she had no real symptoms of any sort that would indicate that she could be positive for coronavirus or that she should have COVID-19 disease. What do we do with this individual? Do we bring her to the normal ward and do a PCR test with a nasopharyngeal swab? And then we, after having her on the normal ward, decide what to do with her after the test. For example, isolate her. Or in the other way, we are a bit concerned. We isolate her first, do the test, and then we decide after the test to bring her to the normal ward. So we are more concerned about that Meyer of having a disease, or we don't care about any PCR tests and we say, okay, there's a risk that she has the disease and we will isolate her. Now, that is completely unrelated to the answer is completely unrelated to the fracture condition. So it could be any other condition for an individual coming into a high-level and high duty hospital. So I want you now to decide whether A, B, or C would be your choice of handling that individual patient in your hospital. Being not that much concerned, bring her to the normal ward, isolate her and do the test result, or being very concerned and isolate her until discharge and not even doing a PCR test. So you're very active. Normal ward, isolation, isolation until discharge. So if you would have a lot of isolation beds in your hospital, then you could opt for option 3 and bring her to the isolation bed. But then you probably, within a couple of days, your isolation ward would be completely full with patients and you would have to close your hospital. So option 3, is probably not the one you would go for. So bring her to the normal ward would mean you are not concerned that the individual has been infected by the coronavirus. Bringing her to the isolation ward would be the case if you would be concerned. So now, what is the information you would need about that patient of whether you should be concerned or you should be not concerned? And that information that you would need to decide to go for option 1 or option 2 would be the prevalence of the disease in this individual, the pre-test probability of that individual coming to your hospital of having been infected by the coronavirus. So you would need to know something about the prevalence of the disease in the population of this particular individual. So in order to estimate the prevalence, you can actually use the numbers that are being published by the different authorities about the number of people being tested positive. This is not actually very accurate number of the prevalence, but it gives you a good indicator of the prevalence. Numbers are changing a lot. These are the numbers from last month. They are outdated already because of the increasing numbers all over Europe. In Germany, at September, we had a prevalence at most of the locations within Germany of between 0.01% to 0.02%. In Italy, the numbers were slightly higher, but still were very low. But we had throughout Europe some hotspots in several parts of the industry, in hotspots related to parties or to events in hotels, so that at some locations there was a quite high prevalence of, in this case, up to 20%. So this is the prevalence. If your individual comes from the vacation back from Italy, you have a low prevalence. If your individual works as a waitress in a hotel that turned out to be a hotspot, you have a high prevalence. So your decision of taking her to the isolation ward or not would certainly depend on whether the individual has either a low or a high pre-test prevalence. So you need to know about the prevalence or the risk group. The next information that you need to know is about the specificity and sensitivity of the PCR test being performed in individuals. Those tests are around for not longer than 6 months, because they had to be developed after the coronavirus had been detected. And so you see that the publications that report about the sensitivity and specificity about those tests, they are from very, very recent publications. And the numbers, they have a wide margin. So the sensitivity with regard to how sensitive is the test to actually detect a patient that is being positive, they range between 60 and 90%. And we just assumed a sensitivity on the upper end here of 80%. So let's assume the PCR test has a sensitivity of 80%. Similarly, the specificity is a bit higher. Those that are not having the disease are being tested negatively. The probability is 89%. So we have this specificity and sensitivity, and we have this prevalence. Let's say we have a 20% prevalence of that individual coming from a hotspot. What I want you to do is very similarly to what we have done for the breast mammography, to calculate the ppb and the negative predictive value and the positive predictive value from a 20% prevalence with 80% sensitivity and 89% specificity. Now I will give you 5 minutes or so to fill in the numbers in the 2x2 table, which you should have available on your PDF printout. I'll look at Marianne. Yes. So please use the number of prevalence 20% and 80% and 89% for sensitivity and specificity respectively. So the local audience here is still busy with scrambling numbers on their paper sheets and calculating what information can be obtained from the PCR tests being positive or the PCR test being negative. So I hope you had been busy calculating the numbers, and I also hope that you were able to actually use the knowledge obtained in the first part of the webinar to calculate the information that is necessary. So we now look into the information that is obtained if a individual coming from a hotspot hotel with a high pre-test prevalence and with this PCR test, having had a test, a PCR test, and now we would like to interpret the results of the test being positive or the test being negative. So, what is the pretest probability in the hotspot hotel? It should be the easiest of all the questions because that information was provided. What is the pretest probability? And I see that people are printing in the correct numbers because the pretest probability in the hotspot hotel actually is exactly the prevalence in that hotspot group, which is 20%. This is actually based on an event we had here close to our hospital, in which a waitress in the hotel turned out to be positive and then infected 1/5 of the workers in that hotel, and that will give us the value of those 20%. Now, using this information of the pretest probability and the accuracy of the PCR test, what is the positive predictive value in the hotspot hotel? Have you been able to calculate that? Positive predictive value. So this would be the probability that Frau Meyer from the hotel with a positive test result has the disease. So Frau Meyer, coming from that hotspot, has a pretest probability of 20%. Now she is tested and has a positive test result. That, in fact, should at least increase the probability that she has the disease. So those that calculated the 5% did somehow something wrong. But at least the same amount of people correctly estimated that the probability of having the disease was increased after the test is performed, and 3 of them actually got it right with the 91%. Now, if Frau Meyer got a negative test result, does that mean she is healthy? What is the probability that Lise Meyer with a negative test result really is healthy? So before the test, the probability of Ms. Meyer to be healthy was 80%. And after the test, the probability that she is healthy should be increased. The question is only how sure can we be that she is healthy? And the correct answer is, as most of you have found out, 95%. Now let us give the solution for this example. We have the considerable high pretest prevalence, pretest probability. Now we do the test on the individual and we get a positive result or we get a negative result. And I just, again, fill in these numbers. I make up a number here and then do the calculation backwards from any number that can be put in here. To make it easier, I did a number that can be calculated easily, so it's 10,000. The prevalence is 20%, so 2,000 out of these 10,000 have the disease. Those being tested negatively, having the disease, this is the sensitivity. These are 80% of those 2,000 individuals being tested positive, 1,600 tested positively out of those potentially 2,000. having the disease. And this gives us then the information of the positive predictive value. Total number of people being tested positive, 1,700. Positive predictive value is 91%. So this means this individual with a pre-test probability of 20% being tested positive has a chance of 91% being positive, having been infected by the coronavirus. So this really dramatically increases the probability of her being infected. Now, what is if this individual from a hotspot obtains a negative test result? Can we be sure that she doesn't have been infected with the coronavirus? And if we do the same calculation here, these are those that are being negatively tested, not having the disease. So these are the correctly tested individuals without the disease divided by the total number of being tested negative is 95%, which means that the probability of her not having the disease is 95%. Still, there is a 5% chance that she has been infected. So coming from this hotspot still gives you a 5% probability that she is infected. And 5%, just remember what we did during this BioS course, always was this 5% p-value. So this is not really much different from that 5% barrier. So we are 95% sure, but still we have 5% inaccuracy that whether or not she's still healthy. So this is for people who are coming from a hotspot. Just out of curiosity, we do the same exercise for a low pretest prevalence, pretest probability from an individual that has not been in contact with any other people who had the disease. So this is the kind of general population here. And I spare you the numbers here. I will just give you the results. So if you come from a normal population with a low test probability, so for a normal individual not in a risk area, and you obtain a positive test result with this PCR test, then the positive predictive value is 2%. 2%. So your probability of having the disease increases from 0.05% before the test to a dramatic value of 2% after the test. So it's very likely, actually it's 98% probability that after a positive test, you are not infected. The positive predictive value is very, very low because of the very, very low pre-test probability and the not very high sensitivity of the test. However, if you are being tested negatively coming from that population, you might be quite sure that you are not having the disease. So it's quite 100% that you are not having the disease. So again, screening in this low prevalence population does allow you to exclude having the disease, but it doesn't tell you much about whether or not you really have the disease. I found this quite surprising, and it helped me a lot to interpret the current information that is available about the PCR test results. So what do we now do with Vermeer? So it is all about staged diagnostics of the individual. And that is what all doctors do every day. They do staged diagnostics. Yep. Okay. Okay. So there was the question here from the local audience, because this is about an individual being tested and not about the whole amount of PCR tests being performed. Let me first talk about the individual diagnosis here on this patient, and then we talk about the corona screening that is being performed. So the staged diagnostic in the individual patient, the patient comes into the hospital with a certain prevalence from a population that you don't know. Then you check all information that you have available from, for example, the medical history, the corona contact app that the individual has available. You do some evaluation of symptoms of the individual. You ask about potential contacts. You check every day the information that is available from the local authorities about risk factors and hotspots in and around your hospital. And from this pre-diagnostic, you can increase the pretest probability. And by staging, then you have much more information available in the PCR test. So if you then perform the PCR test on an individual that showed up some signs of having been infected with the coronavirus, that increases the post-test probability. So if you are able to increase the pre-test probability by looking at the medical history, then you have much more information that you obtain from your PCR test. So the PCR test alone, as we have seen, if you do it directly on an individual, is not as informative as all the information together that you can obtain from the individual. Now, this is about the individual that comes into your hospital. But how about the screening that is being performed at the German Autobahn or at the airports or wherever people are being tested for being infected with the coronavirus? In those people, you normally have a very low prevalence, and the information for the individual remains very low because it slightly increases the probability of the test. However, this information that you obtain from the screening is, of course, very, very important for obtaining the prevalence in your population. So without knowing the prevalence in your population, you have no idea about the distribution of the coronavirus within the population, and you are not able to calculate the risk for each individual. So that's why the screening has to be interpreted differently. So the screening doesn't make a lot of sense because it allows you to calculate the prevalence. But it doesn't have a lot of information for the individual because of the low pretest probability. Okay. With this, we are done with our live webinar on the BioS course for today. And what we now like to do is we would like to obtain some feedback from you, how you liked and how useful this webinar was for you. And this will be done by, no, I will do that. Okay, I got time from Marianne, but I will do that. So how would you recommend this webinar to a colleague or a friend? Please use the Mentimeter to provide this information for us. You will not see the results. The results are hidden so that we don't start crying here if we get bad results or not that we are starting a party if we get the good results. So it's pretty neutral. So we want you to say, would you recommend this webinar to a colleague? We have 13 answers, waiting for 2 more. One more, come on. Okay, thank you. Next question is, how would you rate the speakers? How would you rate how I did the webinar? Please provide some feedback about the speakers and the content of the webinar. Great. We got 14 answers, and I think that's what we have. Actually, the webinar is meant that you get some knowledge. And do you think you have acquired the learning outcomes that we have defined for the webinar in the beginning about the use of the 2x2 tables? Okay, great. Thank you very much. Next question was, please rate whether we effectively presented the subject, whether the duration was okay for you, and whether you had enough opportunities to ask questions or to provide some feedback. Agree or not agree? Okay, thank you very much. The next one is about, most of you are already in a professional work environment. We want to know how useful the topics that we had provided today were for your professional life. Can you use them in your professional life? Thank you very much. And then in terms of what you are working at, are they really applicable to what you daily do and your daily everyday practice? Does this provide a benefit for your daily work? Thank you very much. And then about the technique, so that we get some feedback. Have you had any difficulties participating in the webinar? And then if you had difficulties, please let us know what was the problem so that we can work on that in the future. Okay, thank you very much. And then some feedback where you can write in your individual thing that you like best or least about the webinar. Please let us know if it's the best or the worst thing that you experienced or whatever. Otherwise, we can't really rate your answer. So there are still some people typing. Okay, thank you very much for that feedback. And if you have any improvements for this webinar, please feel free to suggest improvements if you have, so that the next webinar can even be better as the current one. If you think it was already perfect, you don't need to type anything in. Okay, thank you very much. So we still work and continue on this bioinformatics content. So if you have any topics you would be interested in, you might use this now in order to give us the feedback, which would be a topic that would meet your interests. Beyond that, what has already been provided. Okay, there are many answers. So it looks like there are several topics you would like to see here. Still people typing in suggestions. Okay. So before we conclude, we had this chat function of the Google interface open all the time. There actually were very few questions coming through the chat function, but this would be the last opportunity to use that chat function to say hello or to ask a question. And if there would be no questions coming in. Let me see. Open the chat function here. We would do what? So I don't see any questions from the chat, and I don't see any more questions here. You have the opportunity, if you think about what has been presented today and what was presented yesterday and will be presented this afternoon, to go into that online consultation during this specific time on November 19th. This is next month, next Monday. So next month I will still be available for the time specified to answer specific questions with respect to the BioS platform, and also with specific questions for the webinar we had today. So please use this opportunity to get better acquainted with the BioS content. Otherwise, I'd like to thank you all very, very much for your participation. We had a lot of fun, at least some fun, here in Murnau, giving this webinar for you guys out there in the world. And I wish you all the very best and a good start into the upcoming weekend. And with that, I'd like to conclude this webinar and say goodbye, and till next time we see each other. Bye-bye.